mention oncology, the first thing that comes to mind that I think has everybody looking at this category is the pipeline and the spend that is going on in this category. So there are literally hundreds and hundreds of oncology medications in the pipeline, and we assume that these are going to be very pricey medications. So that's why we're focusing on this. What we're doing to manage that right now is fairly limited. We are basically prior authoring a lot of the new medications to label or level of evidence, and that's kind of where our hands are tied. So in my opinion, what we need to do is we need to figure out how we can get past the political nature and the emotional nature associated with oncology. So we actually have, we work closely with our oncology network, so collaboration is key. So whenever a plan is looking at managing anything, especially in oncology, the collaboration with our providers is absolutely key. So we've got some incentive programs we're looking at, and then we're obviously the other buzzword is pathways. And pathways, this is not a novel concept. It's new for a lot of plans, though, in that we will be looking at really digging deeper into the data and trying to determine value of these medications, and preferring some agents and incentivizing our physician network to utilize these preferred products. So within that are concepts like contracting, which is not occurring now, it will occur, and then outcome-based contracting. There's a couple of examples in Europe where this has occurred. I think this is going to start happening here. And then the other things that have slowly been worked on over the last little while are the perverse incentives associated with route of administration and site of care. I think we've addressed a lot of that through fee schedules. And then again, just is the fee schedule issue. So a lot of us have changed to an ASP model from an AWP or WAC model, and that's helped a little bit. And then the last thing that I can think of off the top of my head is benefit design. What do we do moving forward with the issue of specialty tiers and co-insurance, and how we normalize the benefits between pharmacy and medical, and then even to make it even more complicated is how we go with biosimilars. And in my opinion, as managed care, is totally unprepared benefit-wise to deal with this, especially if we're talking on the medical side with J-codes instead of NDCs. How we drive towards more cost-effective medications. So we need to figure out a way that we don't push too much onto the member through cost share, so that we don't negatively impact outcomes. And then the last thing is more towards this end-of-life issue is, are we going to get to the point of really having legitimate discussions about when it's appropriate to stop therapy? And the example I use is one that came up in the symposium, is where let's say we have a drug that has shown to progress or delay progression of disease by 2 years, but it is not shown to improve overall survival. So we've spent a couple $100,000 to get to that point, and would not prolong survival at all. And the other example would be, even if we show increased overall survival by 3 or 4 months, but it doesn't address the issue of quality of life during that 3 or 4 months, and we spent hundreds of thousands of dollars to get to that point, can we continue to sustain that model, or are we going to have discussions, more harder line discussions about when it's appropriate to stop these therapies or even start some of these therapies?